Okay, I'll take it away.
All right, just let's make sure that I can share my screen.
Oops, I'm gonna need you. There you go, you're a co-host now.
All right. Okay, so, well, actually, let me give a little, while I'm getting the slides uploaded. Can you guys see my screen?
Yes, looks good.
All right, so one thing real quick, I'm gonna need to leave it around maybe 7-8 minutes before an hour. So that leaves us just under 50 minutes, but I think that's okay. So let me give you a little bit of a intro as to sort of what I do and who I am, in case you don't know me. So I have been in the area for close to 20 years now. So I'm a geriatrician. I'm a professor of medicine at George Washington University. And in the past 12 years, since the beginning of the DC medical cannabis, I got into this full force forward for two particular reasons. I had a couple of older patients who asked me to get involved in this topic because they had symptoms that were not managed, or we couldn't manage them without cannabis. And then in 2012, I met #1 world researcher on this topic, Donald Abrams, who became my personal mentor and a good friend. And he kind of pushed me into getting all this started. I have been pretty vocal about cannabis being the safest alternative for probably almost all geriatric conditions. And I hope by the time you're finished with this lecture, I'll convince you that cannabis should be the #1 treatment for at least half of all the geriatric syndromes, including anything pain-related, anything related to cognitive disabilities or cognitive decline, as well as a variety of other conditions. So with this, I propose that we do questions during the talk. This way I can time myself better so that we don't really end up with a typical scenario, which is usually, give a talk and then leave time at the end. Problem with that, if we do it this way, I'm afraid I'll take too much time and you won't be able to ask me questions. So best to put questions in the chat. Another option is, Jonas, if you can moderate and see if somebody raising hand, please.
I'm happy to do that.
Yeah, please pause me and just intervene anytime. I don't mind it at all. I'm very free flowing this way. I see already one question, so perfect. So I'll go through, I'll start, and then I'll come to Kathy's question in a couple of minutes. So my practice is spread between two offices. So the one is the university office where I take every single insurance, whatever GW takes. Unfortunately, wait list there is up to 12 months. And then I also have my own practice, which is GW Center for Integrative Medicine, where it's out of pocket. So just you're fully aware. I have a lot of disclosures. I've been in this business for quite some time. This is my book, so I collect royalties from the book. Toward the end, I'll put in the chat where you can obtain the book. And if anybody is interested in getting a signed copy of it, I suggest you get in touch with me later. We can get that arranged. As I said, I also co-own the practice where I see patients, and obviously in our practice, we recommend cannabis. And while I'm not directly financially profiting from those recommendations, but nonetheless, this is part of my care and I have to disclose it. Lastly, I'm an expert witness on half a dozen of cases related to the use of cannabis. I only use in defense, only in cases when patients are fired from the job for use of cannabis appropriately, or medical cannabis. And then I have multiple different industry involvement, but none of them are paid. All of the advisory fees that I collect, I do not take as financial or stocks. They go directly to our nonprofit AIM Health Institute, which I'll put in the comment, because it's an organization that offers care for people without on Medicaid or on limited budget at no cost to the patients. Sorry, it's a healthaim.org, not .com. So with that, let's proceed with the presentation. So we're going to review some basics, because this is not necessarily a simple topic to understand from pharmacology and from mechanistic perspective. And then we'll talk to you about 3 conditions where I think cannabis shines, and I'll even show you practicalities. Now, this is not a medical presentation in the university, which I do all the time, so I don't need to worry about telling you precise recommendations. If you would be a group of physicians, I would be not able to do that because certain restrictions on how we discuss this topic in open. So interestingly, the cannabis is the fastest growing group of patients who are using cannabis are you. It was completely unheard of 15 to 20 years ago. And now, as you can see, just in 10 years spent, the increase has been more than 5-fold, which is pretty dramatic. And there's an expectation that by the end of 2030, this use will grow to almost 30% of adults over 65 for obvious reasons. So some of the importance, I'm not going to really discuss this in a great detail. I do want to tell you that there are 3 major principles that you need to be aware when we're talking about cannabis. Number 1, each of us, starting when we're born, make our own cannabis our entire life. We make a lot of cannabis, and the cannabis from evolutionary perspective is most important regulatory system we have. It regulates every single function, including everything in nervous system, including all the hormones, including everything in the immune system. It is called endocannabinoid system. I sometimes will just say ECS for the short. I'm not a big fan of long words. So the ECS is not 100% understood. It's relatively recent that this system became a hot topic of a research for a variety of particular reasons, one of them being complexity of the molecular mechanisms here and the difficulty in analyzing some of this. Just to give you a sense, endorphin system or endogenous opioid system has been discovered nearly 100 years ago, while the cannabinoid system has been discovered only about 50 years ago. And most of that research has been done in Israel. Israel has been the first country in the world that officially authorized use of medical cannabis for the entire country. What's not good in young, meaning being high as a young person is not a good idea, negative brain development. Being high as an older adult dramatically improves cognitive function in mice, and we now have pretty clear data in humans. What I'm trying to say is this. The older we get, the less we produce cannabinoids. And putting exogenous cannabinoids does 3 things. It likely prevents Alzheimer's disease, it likely prolongs life, and it likely reverses osteoporosis. Those are the 3 things we know for fact based on the current best evidence. What we don't know are the practicalities. We don't know how much cannabis should you be taking. We don't have any data to say which cannabinoids will work and which will not. We also don't have any controlled trials, meaning we don't actually know whether while you're doing this, you're going to suffer some long-term side effects. I will talk about side effects a lot more in upcoming slides. What you're seeing here in the text, which I don't want to necessarily talk about, is precise data known in animal studies, and we are translating some of this data to humans to some degree, because you really can't say that what's going on in mice is exactly what's going on in humans, although traditionally speaking, for research purposes, that's a fair statement. So a couple other critical things. Why did I say prolong life, reverse or prevent Alzheimer's disease and osteoporosis? Well, because we understand some basic mechanism. We understand that cannabinoids, one of the key regulatory of something called autophagy, which is removal of bad cells. When we don't remove the bad cells, we seemingly increasing risks of cancer, we seemingly increase risk of premature death. So this is quite clear. There is a tremendous interest in learning how to control autophagy. There are methods, for example, intermittent fasting, cold exposure, and some others that are sometimes, or not sometimes, that are advocated to be used as methods of controlling this process. Synaptic communication, so the things that make us humans, right? The emotions, the memories, those are required communication between nerve cells. And one of the key principles of aging is that this communication with age seems to getting disrupted. We like to use the word neuroinflammation or neuroaging or inflammaging. Those connections seems to get, once the neurons don't communicate very well, they're basically a signaling starts occurring that the certain cells begin to die. Now, one of the most effective ways to enhance this communication is cannabinoids, endogenous cannabinoids. Now, can we apply exogenous cannabinoids to do so? We think the answer to that is yes. Precise dosing, precise variations is TBD. However, I'm a huge believer that in my lifetime, not sure about everybody's lifetime, this will happen. A couple other things that just on the side notes as to what enhances this communication. Well, seemingly meditative practices or some kind of mind body seem to be pretty important, as well as intermittent fasting, so not taking calories in, and also avoiding certain inflammatory triggers, inflammatory foods, toxic exposures, etc. Okay, so that's that. This is, I'm going to show you a little bit of an actual concrete data because that's how I operate. I don't like to give statements without proof. So this is probably one of the largest studies coming out of Israel with the founder of this entire field, Raphael Mechoulam. So this is looking at almost 3,000 patients over age of 65 who began using cannabis in an older age, after age of 65. What you can see here, most common indication was pain and cancer. After 6 months of treatment, almost 100% of patients reported improvement, and the pain level reduced from a median of 8 on a scale of 0 to 10 to 4. So that is decrease in pain score of 50%. We do not have any treatment in our current medical standard that comes anywhere near this efficacy. The best treatment we formally have is physical therapy that has about 20-25% decrease in pain scores. Medications tend to give 10 to 15% decrease. So this is about 3 times more effective than any existing treatments we contain. In terms of side effects, I'm actually going to show you a particular slide about this because this is very important. So it does come with this expense of some side effects, as you can see on this slide. They're not uncommon. So about 10% of patients will experience dizziness, a little bit less dry mouth, etc. But what's very important, that it appears that there is currently no data to suggest increased risk of falls, delirium, weight loss, worsened sleep, and worsened cognition. Now, remember what I said in the opening? Use of cannabis in older adults associates with improved cognition, not worsening cognition. And I hope by now you understand why, right? Is that clear? Anybody want to take a stab at why you would expect improved cognition when you get older? Come on, this is not a rocket science. I already explained it. Any takers? I don't know. I like to engage people because otherwise I have no idea who's listening, who's not listening. Just unmute yourself. Yeah, Roseanne, I think you're raising your hand. Just unmute yourself.
Actually, I wasn't raising my hand.
Okay.
I think my iPad just thought that, but I'm finding this quite interesting because I've been talking to a friend about it.
All right. Well, I guess I'll answer my own question.
I think Deb is raising a hand there.
Okay.
Oh, go.
It increases the communication between the synapses.
Exactly. So you basically utilizing what we are losing as we get older. You just taking an exogenous product instead of what we take because we make less of it. Now, by the way, this is a very unusual statistics here. The peak cannabinoid production falls at between age of 12 and 14, and there's no good understanding of why. Usually peak hormonal function comes between age of 20 to 35. So why with cannabis, the sort of high peak is in teenage years, and after that game's over, no one fully understands, or it's not over, it just slows down. But by age of 65, less than 50% production of anandamide, which is the main endogenous cannabinoid, is standard. And that's not an abnormal, that's normal process of getting older. All right, I'm gonna pause and do questions, okay? Because I know you got, there's a couple of them. So first, please comment whether CBD impacts the brain in a negative way as ambient, and absolutely not. So CBD seems to be 100% protective against THC effects in younger adults. So what we know, if you take a chronic pot smoker, and when people smoke pot recreationally, they never take CBD, because CBD decreases high or changes high to something that people don't like. So when you take the habitual cannabis user and you give them some CBD, you're completely blocking negative impact of THC on brain. That has been done not just in animal studies, but in humans. And those studies have been done with neuroimaging, particularly with magnetic resonance images or MRIs. So that is a known fact. So moreover, being anti-inflammatory and neuroprotective, we have strong belief that CBD in the future will be part of Alzheimer's treatment as standard of care. The question, it's not clear when it will happen. Those of you who've been following this field know that in 2019, FDA, so US FDA, has approved use of CBD for seizures in pediatric population, the drug that was approved called Epidiolex. It's a pure CBD. I'm not a big fan of this drug because CBD in that drug used as oral medication in swallowing format. We don't like to swallow cannabinoids because you lose about 90% efficacy. Cannabis is highly lipophilic. What it means is it's absorbed in fat. When you swallow it, it just very little of it ends up in your system. About 90% ends up being lost. When you put it on the tongue, the efficacy of absorption is about twofold better, or about 20, maybe up to 30%, depending on the carrier molecule. So we like to use most of the cannabis as drops under the tongue. But more on that later. Let's do the other question. In your relationship between phages and autophages, not at all, completely different words. They're even spelled totally different. Okay. Experience. I'm not sure VFT training. I don't know what the word experience refers to, so I'm going to skip that. Lower immune system defenses. So cannabinoids enhance immune system. So I'm not sure what the question refers. Lower immune system defenses. Maybe loss of brain cell during adolescence. Right, so CBD protects against loss of brain cells during adolescence. If somebody smokes pot, we do think that there's an actual loss of certain brain circulatory function. The thinking why that happens thought to be more related to the fact that when you overtake THC, that communication between the neurons actually gets disrupted. So there is something called Jcurve with cannabis, and it's a very important principle. If you're ever going to try to use it, you have to find the optimal minimal dose for yourself. If you take not enough, it's not going to work. If you take too much, not only will it not work, it may cause harm and it will not work at all. So it's kind of what we call a Jcurve. You got to find that lowest bottom point which works for you. That's why this topic is a bit more complicated, and trying to do this on your own is probably doomed to fail because you need an expert to guide you on the process. Any difference in the way that you ingest cannabis? Right, great question. So smoking it will give it quick effect, but the problem is that's the most wasteful way of doing it. When you're smoking, you exhale it. And when you exhale it, you lose more than 90% of all the cannabis you just inhaled. So basically, you just burn a bunch of dollars in essence, because of course, everything's pretty expensive in this area. So yes, the ingesting it, and as I said, under the tongue, probably the most effective from the dollar perspective. Now, anybody who ever smoked pot will tell you in terms of delivery system, it's very effective because you get a very quick pain control, and you can dose it very precisely. So for example, let's say you're treating your pain, like a neuropathic pain, a back pain, any kind of pain, actually, pretty much. Cannabis controls it in about 70 to 80% of people almost instantaneously from the first dose you take. But you know what will happen with that if you're not experienced? You're gonna have difficulties finding a precise dose. You're gonna waste some material and you may overdose it. So it's a lot easier to overdose inhaled product. Why? Well, because if you're naive and you don't know how much to take, that's just what happens. It's an overdose is extremely common, but here I make a joke. When you overdose on alcohol, you end up on a highway 95, driving 95 miles an hour, crashing into the pole and dying. When you overdose on cannabis and you're driving on a Route 25, you will be driving 25 miles an hour and you will be rear-ended with a minor fender bender. You'll walk out of the accident without any problems. So cannabis doesn't seem to cause the severe chances of overdose. You just feel weird. It's not uncommon for our emergency room to give me a call and say, Dr. Kogan, we have another one of your cannabis patients saying that they're dead, but they're talking to us on the phone. What's your advice? Well, my advice is give them some fluids, tuck them into the bed, sing them some lullabies, have them slip it off and send them home without doing anything else. Please do not medicate them. So nobody dies from cannabis. There's been an experiment done about 35 or 40 years ago when it was legal to do something like this. They took a gorilla, well, I don't know which monkey, probably a chimpanzee actually, put on in a secured cage made out of plastic fiberglass. So all of the air inside was controlled. And then they start pumping cannabis smoke inside. After 800 cigarettes, poor thing finally died, and they were quite happy that they finally figured out how to kill monkey with cannabis. When they did the autopsy, it turned out monkey didn't die from cannabis, but died from carbon monoxide poisoning. We have no idea what the lethal dose of cannabis is. There's been not a single death attributed to cannabis in entire human evolution. And by the way, the cannabis is the oldest existing drug. It's been first described by in traditional Chinese medicine over 5,000 years ago. It was one of the most prevalent early symptom control medication for a variety of different conditions. And in our own backyard, right here in the United States, until around mid-90s, cannabis was used as a standard of care. It's in the pharmacopoeia. So if anybody is interested, if any of you are historians, go to the US Congress Library and identify old pharmacopoeia, and you will find on the page 52 of 1850 pharmacopoeia, 2 full pages dedicated of cannabis as a standard drug for about 50 medical conditions. And every single pharmaceutical company back then was selling cannabis products. Cannabis was one of the largest industries in the medicine of 1800s and even in the early 1900s, upwards of 1930s. And after that, things have unfortunately didn't go well for cannabis. And I'm not going to go into politics of this because we don't have time. But if anybody interested, I'm happy to talk about it. Okay, so this always comes up. People ask me if I am taking opioids and I am on Medicare, can I take cannabis? What will happen to me? Am I going to be in trouble? My doctor tells me I'm crazy to smoke cannabis when I'm 90. Is that true? Well, here's the data. This is JAMA. Those of you who know, this is the probably #1 US internal medicine journal. It's the Journal of American Medical Association. So this is the formal study that was done on patients on Medicare that's showing that when the cannabis was approved, starting, this is back years ago, their first assessment was done in 2014. So the moment the cannabis was approved, there was more than almost 4 million daily prescription less filled in United States of America in each state that legalized medical cannabis. Now, and you can imagine what that translates to. What it translates to is about 30% reduction in the death related to the opioid overdose. And this is not an accident-related overdose. This is a prescription-related overdose. So what I'm trying to say is if you start smoking cannabis, you're 30% less likely to die from opioids if you're taking them. This is a hard data. This is the assessment of the entire US population of Medicare, right? So this is not something that can be taken lightly. Have anybody ever heard about this before? Have you heard your politicians in the state you're in discussing this? No. Why? It's a scary news. What it means is that until now, cannabis has been suppressed as a treatment choice, and because of that suppression, we are killing upwards of about 50,000 Americans every year from opioids. And this has to stop in a way, right? But this is just one solution, right? It's not necessarily the only solution, but the data is there. Okay, so let's go back to questions. All right. Please comment on the health effects of the higher potency. So this is completely irrelevant question, Anna. It basically, you're following a crowd of everybody saying this. This is totally irrelevant. It doesn't matter what potency is out there in the plants, because most of what you're going to be using as a patient, if you're ever going to choose extracts, and they're going to be made specifically for you, for your given condition with a particular ratio of CBD and THC, and you will be able to dose it precisely. So it makes zero difference whether the starting material is 20% THC or 100% THC or 5% THC. As long as the extraction is done right technically and it does not have contaminants, which is a whole separate point of discussion, then it makes no difference. So this whole point is totally irrelevant when we're talking about medical cannabis. Now, yes, if you're talking about smoking pot on the street from the whole plant, that is not this lecture. If you came expecting I'm going to talk about this, leave, because that's not what we're talking about. I'm not advocating for using pot recreationally. I don't think that the state of high needs to be achieved by external methods. And those of you who've been following my work will know that there are lots of other ways to do this. For example, if you're not aware of meditative effects on brain, please read Altered Traits. And this explains well what happens or Michael Pollan's book also. This explains why we don't really need the state of high. Okay, how was CBD taken in various studies? So most of the time CBD is looked up on in an oral administration and usually in a capsules or liquid, but swallowed, which is what I disagree with. CBD needs to be taken under the tongue. The best absorption of most cannabinoids that are not acidic comes from direct application under the tongue. Okay. Good question though. How to find a Jcurve for individual? Ruth, perfect question. It's not that easy. You have to have a lot of experience. So usually what I do, I start with 1 milligram of THC placed under the tongue. And then after 3 to 5 days of not changing the dose, I start recommending gradual increase by about 1 milligram per day. So it may take you a couple of weeks until you get to the dose of, let's say, 10 to 20 milligrams. But this way you're A, not going to overdose, and B, you have much more likely to identify that precise Jcurve spot, because eventually once you start taking a little too much, you'll realize, wait a second, today effect is the same as yesterday, but I'm taking more. That's it. It means you just passed the Jcurve. Ruth, let me know if that makes sense. Okay. Okay, Kathy, great question. What kind of harm can too much CBD do? Frankly, I don't really see, and the data supports this, we don't actually know. We think that CBD can be a little too sleep inducing, and it could be somewhat depress producing, but at the super high doses and very temporary. So it's not like you take it and then you're depressed for a long time. No. The biggest concern with CBD has nothing to do with symptoms, and it's a theoretical concern. We know that CBD activates or changes the way our liver metabolizes some medications. So for that reason, you should never take a high dose CBD if you're taking medications that are liver metabolized, because there could be theoretical overdose or underdose of medications, depending what medications you're looking at. This topic is pretty complicated, and everything I'm telling you right now has been supported by theoretical evidence, but not by practical cases. We don't actually know if this happens in real life. We don't know whether someone should be taking 1,000 milligrams of CBD a day, which is extremely high dose, or if this interaction can occur with the doses that are more realistic, somewhere between 50 or 100 milligrams a day. But it's a great question. Can DC prescribe for patients who live in Virginia? No. The doctor needs to have a Virginia license. I happen to have licenses in all 3 states. DC has a reciprocity with Virginia, meaning, let's say you're a Virginia resident, you get the card from a doctor who's licensed in Virginia. But of course, you know, Virginia is conservative and their cannabis law is completely crazy and bad, and their products are disastrous at the moment. Nobody can get anything reasonable. So most of my patients who I license to get cannabis card in Virginia get the actual products from district. The reciprocity law in DC also works with Maryland, but Maryland does not have reciprocity with Virginia. So just FYI. So if you're either in Maryland or in Virginia, you can get products from district, and district has the longest program. So their products are probably the widest menu, although Maryland is rapidly catching up. And Maryland's program is much bigger for obvious reasons. It's a much bigger state. And Maryland also did something very smart early on. Instead of taxing individuals, Maryland is taxing dispensaries. So what dispensaries have to do, they have to be aggressive. So there's a lot of dispensaries in Maryland. In district, there's only 6 or 7, and in Maryland, there's over 200. But I'm sure Virginia will start catching up, just a matter of time. Okay. Do you anticipate a time will come, maybe it's here, where anyone who is entering middle? Yes, that's exactly what I was saying. I anticipate that in upcoming future, just like there was a bad recommendation of taking aspirin daily, which is no longer recommended, I do anticipate there's going to be some utilization. Let me tell you how I use cannabis in my own family. I'm not afraid of discussing this because it's Maryland is legal state. So I use it for all of my family, including my pets. Well, the only part of family we're not using it for is our chickens and our bees. But I am using it for for 2 adults and 2 children, and for the dogs. So for kids, I primarily use topicals on bruises and cuts and things like, you know, I have 2 teenage boys who love snowboarding and skateboarding. So injuries abound, and all kinds of aching and all kinds of minor pains. So they get mostly topical. I don't use any other form in my kids. My wife has some inflammatory conditions, so she sometimes will take CBD under the tongue, and then the same with me. However, I would say the #1 use in our family is topical by a mile. For all kinds of different topical conditions, including rashes, including bruises, including different things like that. And then for my dog, who's a German Shepherd, who's maybe will end up in a Guinness book because she's now 16 and a half, and German Shepherds usually live till about 12. So she's been on CBD oil now for about 2.5 years on a daily basis, both for cognitive. She is developing an Alzheimer's. Actually, dogs can get Alzheimer's. And so she's getting some CBD oil and some other cannabinoids, low dose THC and CBG, as an attempt at trying to slow down her aging and her cognitive decline. What about gummies? No, they're not any better than pills. The problem with gummies, you're getting sugar, and also the problem with gummies, often they're isolates. So listen to this very carefully. You don't want to take isolated cannabinoids. You want to take cannabinoids that are in the full spectrum of entire extract. Why? Well, I'll give you a philosophical answer to this. In botanical medicine, we usually think that nature is smarter than us, that over the thousands, if not millions of years, it figured out how to combine different ingredients, and trying to isolate something almost always, and actually not almost always, does not work as well as a whole extract. The only reason to do extraction is to get FDA approval. There is no other reason. From medical perspective, there is never a situation in which you want to get a pure isolate, because when you do that, you have to dramatically increase the dose of that isolate. And more importantly, when you do that level of isolation, you're running risk of contaminations and you're running risk of losing potency of products. So from the perspective of pure pharmacokinetics and pure medicine, it makes no sense. And it's only done to comply with regulatory schemes, because it's very difficult to study a complex treatment strategies. So if I say that I take a cannabinoid extract that, by the way, has about 500 active ingredients, about 200 cannabinoids and few hundreds of other molecules like terpenes, flavonoids, antioxidants, the modern medicine has no way of saying what does what. We simply don't know how to do it. So for that reason, appropriately, research funding agencies like NIH will prohibit use of such products, saying that we can't figure out what works. Thus, we don't want to give you a grant. So please isolate active ingredient and then we'll talk. The problem with that approach, you can't really do that and expect a very good efficacy. With cannabinoids, the simple answer to that is, turns out that if I, for example, take beta-carotene or pinene, pinene is a smell molecule in pines, you know, that strong pine smell. Turns out if I combine that with THC, I dramatically enhance potency over pain control. And this is why, like, if you look historically at how cannabis was used, it was always used as a whole plant, whether it's a whole plant extract or the actual boil or actual plant itself, let's say inhaled, smoked. That's the historic use. Now, will we have in the future time when a company will isolate different ingredients, put them together, and then use that as a treatment? Maybe. And I'm sure that the pharmaceutical industry will be aggressive at trying this. But going back to the question about gummies, you want to get that full extract. So you want to make sure that your gummy contains the full extract and not just THC. Okay? Kathy, thanks for the question. I hope that this was an appropriate answer. Okay, I have had successes with gummy from a company called CBD. Okay, so I'm not going to particularly discuss any specific products. I think, well, this is not CME, so heck, why not? Sure, I think that VTF training, I don't know who you are. Maybe you can say your name, otherwise I keep saying VTF training. So yeah, so this sounds like you have a 10-to-1 CBD to THC combination. I love that ratio because that ratio has a lot lower risk of side effects. It probably would not be my preferred choice for pain, because for pain, we think that the probably better choice would be 1-to-1 CBD to THC, or even more THC than CBD. But you can have a very good response of this product for something like anxiety or sleep, as an example. And by the way, I'm going to put the plug for the book. The book has all of this precise specifics in there, and I can actually tell a little bit more about it before we end.
And by the way, if I can ask, I'm the one with the gummy, and I'm wondering if the oil, the CBD oil, is more effective than the gummy.
Correct. I would expect that. And the reason twofold. So one, your gummy cannot be oil-based. The gummies are always sugar-based. So they're aqueously made, meaning that the absorption from the gummy has to happen past stomach. It cannot happen, well, it can happen in the mucous membrane, but you're going to have to chew it thoroughly, leave it there. It's just not a very effective delivery method, right? But the advantage of gummy over the sublingual drop would be that it will last a lot longer. It's an important concept. When THC passes through the liver, it gets hyperactivated, and the metabolite of THC lasts a lot longer, and it's about 3 to 5 times more potent. So there is a benefit of swallowing cannabinoids if you're looking for prolonged relief. For example, the gummy would be better for sleep if you're unable to stay in sleep, if you can fall asleep, but then you wake up at 4 a.m. So for something like this, the gummy with some THC and CBD would be better. Anna, I agree with you. There's just not a lot of research. I'm trying to point out to the research I have. The reason we don't have a lot of research is very simple. All of the products that contain more than 0.3% of THC are still Schedule I controlled substance. Unfortunately, what that means is that you cannot obtain federal grants to study effectiveness. You can only obtain federal grants to study side effects. With cannabis, we sort of done mostly studying side effects. It's been done for many decades, and I think a lot of this has been elucidated already. I have covered some of those side effects. There are some others, but I don't think I want to go and talk a lot about it. But we are entering finally the major change in the research. What has happened in the past few years is that the government finally said, okay, we will allow the products that are currently sold in dispensary to be studied in clinical trials. Before that, if you wanted to do a formal clinical trial through the registry of the government, you had to obtain the products made by the government. And those products, you can only obtain a flower that patients will have to smoke or vape. There is no gummies. They didn't have any gummies, no oil. They only had 2 different flowers that were made back in the 50s and 60s. A lot of those products have THC completely destroyed because they've been sitting in freezer for 20 years. Nobody uses those products. They're just not available for general public. You basically don't want to study something that's just has no application. But I completely agree with you. What I'm telling you is there's synthesis of research I can provide. And if you, Anna, if you're interested in research, I can share it with you, but I recommend you Google 2017 National Academies of Science Medical Cannabis Report. It is the largest assessment that was led by Dr. Donald Abrams until now. And basically in that report, the experts in this field have agreed on the following, that for chronic pain, cannabis is a grade A recommendation that should be first-line treatment for any existing chronic pain, except for something called fibromyalgia. For fibromyalgia in 2017, the data was not quite there. There's a little bit more data now. And the second area where cannabis gotten grade A recommendation with chronic nausea and vomiting, specifically relating to chemotherapy and cancers. The other evidenced applications are much less so. So sleep was not as, and is still not as evidenced. Things like cognitive decline and advanced Alzheimer's disease. I often do recommend it for those conditions when patients start to get agitation related to Alzheimer's disease, and several countries, whole country-wise, Canada, for example, approved cannabis for that indication. But the evidence is just not as great. And evidence generally is just hard to come by here for specific clinical indications, despite the fact that we have a tremendous amount of evidence in animal models and also from observational studies. The problem with observational studies, they're just that. They're not controlled, they're not randomized. It's hard to know how to apply the observational data when you don't actually know what happens if it's not been compared to placebo. So I completely agree with you. So I think we're running kind of slow, but that's okay. We'll just end wherever we end. So I'm going to walk you, probably we're going to have to end on the insomnia because I don't think we'll have time to talk about the agitation, anxiety, and delirium and dementia. So chronic pain in adults. So you all know that we have a opioid crisis because we really, until recently, have not allowed effective chronic pain strategies that would be insurance-based. So the things that are very effective, like acupuncture, for example, is just not really well covered. Of course, physical therapy is covered, but other things listed here are not super well covered. And you know that most of the chronic pain is treated with medications, and polypharmacy is the #1 killer of older adults. So actually, if you didn't know that, that's another tidbit of information. The actual medications are now third most common cause of death on average in the United States of America, and it's the first most common cause of death for older adults. So our tools that we use in what I use in my own practice, unfortunately, have a lot of problems. So we acknowledge that. And that is probably the main reason why we need to look for other venues for other treatments. I mentioned the ones above: acupuncture, massage, chiropractic, and osteopathy, but those are uniformly too expensive, generally speaking. So here's a case of my patient. She was admitted to the hospital, and my fellow, when I was covering, was called because the patient was deemed to be likely to expire from delirium. So they couldn't figure out what was going on with the patient. When my fellow investigated the records, turned out that the patient had recently been increased on this medication called gabapentin or Neurontin. And when we checked the patient's level on admission, 24 hours after the patient ended up in the hospital, the level was still highly elevated. So we have slowly tapered, delirium resolved, patient did surprisingly well, all cognitive problems resolved. And of course, then the question was, when the patient's pain started to come back, what do you do? So what we did is we tried this kind of approach, which I often recommend. Unfortunately, this patient was on a pretty limited budget, so she couldn't afford acupuncture and supplements. So she ended up just staying with a low dose of THC to CBD with just 2 milligrams twice daily. And after 3 days, she slowly increased. And her bill, by the way, was about $80 a month. That about all she could afford, just to give you a rough sense of the cost. So again, I said, start low, go slow. I love this third part: deliver where it needs to go. What do I mean by that? Let's say you have a pain in the foot and that's all you have. Well, start with topical, because if the topical gonna work right over the pain, you're gonna tremendously decrease amount of side effects or chances of side effects, right? Because your systemic absorption will be very small, and you're much more likely to also save a lot of money, because if you put a small amount on a given area and you get the area controlled, the pain-wise, then you don't have to take more. So game with cannabis, take only what you need, don't take more. I'm going to keep repeating this. This other point's a little too advanced. I tend to like mixes of different cannabinoids. There is some data potentially to suggest that when you combine different cannabinoids, especially acidic forms, the THCA and CBDA, you make it more effective, but I'm not going to go there. I think it's a little bit over the level of today's chat. And I'm a huge proponent of suppositories for back pain and pelvic pain, because again, deliver where it needs to go. Why would you need to swallow something where if you have a back pain, if you put the suppository, you get it a lot closer? Now you have to get over the fact that you're putting something in your rectum or vagina, but trust me, us geriatricians, we're not ashamed of all kinds of methods as long as we can help our patients. And by the way, they do work. There's been a lot of debate over this in our field, but for the local symptoms, suppositories can be quite effective. So I think I'm gonna finish I'm gonna skip this. I'm just gonna show you on the case of an sleep problems, and I think we're gonna have to end there, unfortunately, because I have another meeting. So my experience with sleep and older adults and cannabis has been very profound. The data on that is not very strong. We have a lot of data to suggest that similar to opioids, when the states approve cannabis, the use of over-counter sleep medication goes down. But we don't actually have a controlled randomized studies to show that for sleep in older adults, cannabis works really well. This is my experience. So to the honest point, yes, I do not have a stronger evidence than that. So I'm giving you a full disclosure for that. Usually what I recommend that people take sublingual low doses, starting at about 1 milligram of 1:1 THC to CBD or THC to CBN. CBN is a cannabinoid, I forgot what the N stands for, but it's an option that tends to work quite well, and local dispensaries do have CBN. And this is a case that I'm actually going to skip. I'm just going to show you how he did it. So he's been not sleeping for 20 years. He brought a whole case of records. He's been to Mayo Clinic, Cleveland Clinic, multiple medications, nothing works. So we kept him on 6 milligrams. Now it's 8 years. He sleeps completely fine. He tapered most of his medications off. And that's it. I'm going to skip forward just to my book. So if anybody interested, what I will do, I'm going to stop sharing and I'm going to put a link to my book in the chat. And I don't know if you guys know, but there is a way you can save the chat. So if you want to buy the book later, you can do that by saving the chat. And by the way, if you do that, also all of those other great questions that were there are going to get saved. So
I have the chat to save automatically, so it'll save that, which is good.
Great. So just give me 1 second because I gotta get the link. All right. Well, let me put this link. It wasn't the link I wanted to save, but okay. I wanted to give you Amazon link, but this is fine. This is the link to an actual penguin. It's a Random House. So this is the book to the link to the Random House, but you can buy the book from any store, from Barnes and Nobles, from Amazon, from anywhere. And you don't have to buy it in paper copy. You can buy it in Kindle or Audible. I'm kind of proud because the person who recorded the book was the one who did The Life of Pi and Harry Potter. So I'm proud that they gave me a voice artist that is famous, much more famous than me, by the way. Okay, so thank you so much. Please let me know if you wanted to come back. If this was valuable, I'm happy to come back to give more specific presentation. And yeah, Jonas, if you don't mind sharing the link to the recording, I'd love to, just for my own records, to save it. And I wish everybody happy weekend. And yeah.
Great. Thank you very much.